Awesome. So I think we can go ahead and get started. Thanks everyone for joining the N3C Community Forum weekly meeting. We have a couple of items today, so maybe we can just turn over to Tiffany to make a quick announcement, and then we'll do a quick introduction to Giselle.
Perfect. Thank you so much for allowing us to make this announcement. I'm speaking on behalf of Andrew Williams and myself to announce that we will be starting up the working group to connect concepts in the OMOP Common Data Model directly to concepts in different open biomedical ontologies, with the goal of providing a stronger link between the clinical observations and underlying biological mechanisms that drive disease. So the goal of this working group is to leverage existing tools like LOINC to HPO and OMOP to OVO to help make more progress towards connecting the kinds of observations and clinical data we have available in the enclave to different types of biological knowledge. And if you are interested in joining us and helping work on this project, please reach out directly to myself or to Andrew Williams, and we can get you updated information about our meetings.
Great. No, thanks, Tiffany. And that's really exciting. I think this is going to be a very, very important effort. I think, one of the clear strengths of the N3C, has been the sort of development of multilingual data representation methods. And with all of the work on concept mapping, we have huge numbers of real examples now. So I think that's going to be really excited. I'm personally looking forward to joining your group. So I encourage other people as well. So the N3C continues. We have 65 sites release data in the pipeline, 273 DUAs. At least in one definition of COVID positive, we have roughly 3 million cases, and we continue to characterize the nuance of different definitions of COVID positivity. So without further ado, our main attraction, Giselle Corbie, and I think you're going to share slides, and Warren, you were going to do the introduction.
I am very pleased to be able to introduce Giselle. Dr. Corbie is the Keenan Distinguished Professor of Social Medicine and the Director of the Center for Health Equity Research, which she founded at the University of North Carolina in Chapel Hill. I've had the pleasure to work with her during the COVID pandemic on something she's going to be talking about, which is the RADx, which is the rapid diagnosis for COVID for underrepresented populations, underserved populations. I got to say it right because I'm part of it too. And she's going to talk about the infrastructure we've been developing. Something that I'll mention that you may not find unless you search for it this way. She also has a podcast that she's been doing for a little more than a year on a different kind of leader, and I'd encourage you all to check that out. It's a great something great to listen to when you're commuting or whatever it is that you do every day that would let you listen to a podcast. So with that, I'd like to hand it over to Giselle. And Giselle, can you share your screen?
Now I can. Thank you so much, Warren, for that really generous introduction. And we'll add you to our PR group for a different kind of leader. I'm hoping folks can see that okay. Are folks able to see the screen? I know that it was, we had a size difference before. Warren, how does it look now?
It's still the same way, but why don't you just go ahead? It's I think everybody can read it.
Okay, my apologies for the tech. I can't figure out why it's working this way. So I'm really grateful to be here. It'll be a little bit different talk. This is not really talking that much about the data infrastructure, but more about how do you create an engaged infrastructure to support this kind of research during a pandemic. And I've been very fortunate to be in this work with Mickey and Warren in thinking about it. So as you all, probably more so than anyone, although when I looked on the N3C website, I didn't see a work stream or work group that was working on disparities. I saw some clinical focus as well as cross-cutting work groups. So I'll be interested to hear how you all are grappling with this issue around inequality around COVID. You all know, probably more so than anyone, because you're that close to the data, about how the kind of burden this pandemic has placed on communities of color. We know that severe cases and death are disproportionately amongst Black, Latino, or Latinx and Native American populations compared to white Americans, American Indians, or Alaska Natives are hospitalized at 4 times the rate. Latinos at hospitalized at almost 3.2 times the rate. Black Americans at almost 3 times the rate, and are dying. Black Americans are dying at 1.5 times the rate. American Indian and Alaskan Natives 1.4, and Latinx at 1.2. And you see this here as well in terms of the proportion or the percentages over white Americans that we're seeing in this pandemic of cases, hospitalizations, and deaths. And this bears out and has been fairly consistent when we started getting data around minority, racial, ethnic minority, as well as other underserved populations. And there, to go further, you can see amongst the disparities, there are actually differences by sort of country of origin, where US Blacks, depending on age, have a much higher burden compared to Haitian-born Blacks and other West Indian Blacks. Mexican Americans or Mexicans and those from Central America have much higher rates at the same age groups compared to other Latinx populations. And so we are left sort of scratching our head and trying to figure out why. So just to make sure we're all on the same page, I'd like to offer folks this definition of health equity. This is from Kamara Jones, who was the president of American Public Health Association several years ago. And it's one of many definitions that are out there. But I think it's an important one to ground this kind of conversation in, is that, first of all, she writes that health equity is the assurance of the conditions for optimal health for all people. And this is what I like about this first part of the definition is it requires us to think about health equity as a continuously active process. The assurance of these conditions has to be intentional, active, and continuous. And achieving health equity requires valuing all individuals and populations equally, yet recognizing and rectifying historical injustices and providing resources according to need. And so when you look at this diagram from the Robert Wood Johnson Foundation, you see that we can't give everyone the same 2 wheels of transportation, that we actually need to think about these modes of transportation based on the needs of the individual. Making sure everyone has the opportunity to ride their bike and enjoy this beautiful weather that we've been having, at least in North Carolina. And what I like about this framing around health equity is that it incorporates health disparities. We know health disparities will be eliminated once health equity is achieved. I'm seeing some things in the chat which is a little challenge, or okay, 3 things in the chat. Okay, yes, I did see the SDOH domain. Thank you, Liz, Warren, and Andrew. And I just didn't get a chance to dig in to see what was there. We all know that health is just the tip of this iceberg. There are many things that go into health. Social determinants or structural drivers of health is what I prefer to call it. And this is just a subset of many things that are below the surface that we need to get to and understand. These social determinants of health, the World Health Organization characterizes these structural drivers or social determinants of health as the factors where people born, grow, work, live, and age, and the wider set of forces and systems that shape the conditions of daily life, including the economic policies and systems, development agendas, social norms, social policies, and political systems. And that's small p political systems, I would suggest, that shape the conditions where people are born, grow, work, live, and age, pray, and love. And these, I like this diagram that was in the American Journal of Public Health that really allows us to think at these multiple levels, how these social determinants of health or structural drivers of health, and listed here as a social conditions and policies, institutional context, how that eventually gets under the skin. These distal factors get under the skin to drive health inequalities. And this is the framework, this is the backbone in which we found ourselves in this pandemic. In addition, converging on this pandemic has been this sort of resurgence of thinking about how we center the needs and interests of our most vulnerable in our community. Bell Hooks in her treatise that challenged the feminist movement talks about the need to reframe the feminist movement and really any movement that hopes to elevate the needs and interests of a historically marginalized population by centering the margin, centering the needs and interests, prioritizing the needs and wants of those that are most affected by a condition, our patients and the communities that we hope to serve with this work, making sure they're at the center of the work that we do. It democratizes the process to include this direct participation by the stakeholders, the design and the evaluation of impact. And it really marks a pretty radical shift in power dynamics of how we do our work and who it's intended to work for. The other idea of centering the margins is reframing with the strength-based approach to health equity. And that's, I sort of intimated that in just explaining why I like that definition, is that it focuses on strengths rather than deficits. There's a growing interest in engaging communities, patients, and stakeholders as partners in the process of research. And we've seen this throughout the NIH. For those of you all, and I think most on this call are affiliated with CTSA, we've seen the community engagement core move from one that was just to sort of help with recruitment to now that's a really substantive part of the work that we're doing. And even in the most recent iteration of the RFA that we're responding to, that really asks us to center health equity in any application. So this idea of engaged scholarship is often used to address the health of populations who identify with underserved, economically constrained minority communities, or otherwise historically marginalized communities in our healthcare and health systems. It shifts the role of researcher from the sole creator of knowledge to co-creator with stakeholders, and recognizes and acknowledges the particular expertise of stakeholders that have that lived experience as critical to solving complex problems in health and healthcare. And see, these are our patients, our community leaders. In the case of N3C, and in the case of the work that we're doing, RADx-UP, it's the clinicians that are in healthcare systems and other providers. It's the idea, and the data shows that this is a better process, and the outcomes by integrating and highlighting these diverse perspectives. The funders have real interest in engaging stakeholders as partners because of the potential to improve the quality and the relevance of the research, increase community capacity in translational research to actually affect change, and also the potential for the process and outcomes of research to address health inequalities in historically underserved communities. So this sort of, as we think about the spectrum of engagement, I'd like to sort of provide the spectrum. It moves on the left from increasing levels of community involvement, impact, trust, and communication flow, all the way from outreach, which I would say 20 or 30 years ago when I started doing this work, a lot of it was focused on outreach. There's a little community involvement. It's really sort of unidirectional. It is asking community members to be part of the research process and come in, but doesn't acknowledge the expertise that comes with them. Moving to consulting, to involving, to collaborating, and then this idea of shared leadership that's a bi-directional, intentionally bi-directional. And I'm getting a signal that my internet's stable. If someone can chat in, if they're having trouble, I would appreciate it. Looks like everybody that I can see is still moving, so I'm just going to keep going. Warren, text me if I need to do something different, okay? So it's on this backdrop, in the midst of health inequalities, let me see, I see a chat here. Okay, audio's fine so far. Thanks, Dave. In the midst of these inequalities, that the RADx portfolio of projects was actually born. And so RADx-UP, RADx Underserved Populations, which is in the second to last blue bar, there is one of 4 initiatives across the NIH to address the COVID-19 pandemic through testing initially and probably later on. It is really the largest investment in supporting the health of underserved populations and understanding the genesis of health inequalities that, as far as I know, has existed. This is a $500 million investment, and across the RADx initiative, which stands for Rapid Acceleration of Diagnostics, this is a $1.4 billion NIH initiative to advance technology, to support engagement, and to really help to address health inequalities around COVID-19 morbidity and mortality. So our goal is to, overarching for RADx-UP is the consortium to evaluate how to increase uptake and access to COVID-19 tests in underserved population. That was the stated goal for all of the projects and the stated goal for us at the coordinating center. And I started RADx-UP, which is the initiative Warren, myself, and Mickey Cohen-Wolkowitz are leading in September 2020, so just a year ago, with 69 projects in the phase 1 of the award, and us at the coordinating center. We were all funded on pretty much the same day or maybe a week apart. This past spring, we have another initiative, Say Yes COVID Test, that I'll share a little bit about, and then the Safe to Return to Schools project. So another 16 projects added. And then this fall, we have another 3 added, and we have a whole phase 2 that's going to be added later on, either this month or the beginning of next month. And this RADx-UP, again, is, as far as I know, the largest initiative to really focus on community engaged research, partnering with those in the communities most affected and impacted by the pandemic. The idea, again, is to leverage those relationships and maximize the kinds of expertise that's needed to solve the complexity inherent in the pandemic. And so this is what our portfolio looks like so far in terms of the across the country. Not only we have a couple states that we're not in yet, but we're doing pretty well in terms of coverage across the United States. And then you see on the right-hand side the number of projects that are specifically focused or include Hispanic, Latino, or Latinx populations, Black or African American, older adults, children, Asian American, American Indian, pregnant women, Pacific Islanders, Native Hawaiians, Alaska Natives, and those that are incarcerated. I'm going to move through this. You also see the project settings: community health centers, urban centers, in-home or at-home testing, rural communities, in schools, public housing, nursing home or long-term care facilities, as well as prisons or correctional facilities. This is the infrastructure or the structure that we have. We have an administrative and coordination core, and then we have 3 additional cores that include a testing core, a community engagement core, and the data science core. All of these sort of work together, but I'm going to focus on the community engagement core. This is our team. I would say a pretty outstanding team of folks. We're lucky to be joined by Al Richmond as one of our key collaborators in Community Campus Partnerships for Health. And there's shared leadership across these cores. The goals of the Coordination and Data Collection Center, the coordinating center for RADx-UP, is to accelerate community implementation science via this agile, flexible, and participatory and transparent sustainable coordinating center to amplify and disseminate community best practices for successful implementation of testing strategies and vaccines, to support the data collection, integration, and sharing while preserving the necessary data protections, and to use this infrastructure to support research around COVID-19 now and also health inequalities in the future. Our principles are that the communities are the center of our work, And my hope is at the end of this, you'll be able to see how we've tried to focus everything in developing this community of practice. Data sovereignty, because of the number of tribal and other sovereign entities that we're partnering with, or in our projects are partnering with, data sovereignty protections and sharing with communities and participants are essential in building trust. There's an intentional support of study teams that are critical to streamline results and troubleshoot, and broad dissemination of program activities, data, and best practices. Warren, I saw you come off video. Is there something in the chat that I need to pay attention to? We're good?
Nope, we're all good.
Okay.
I'll let you know if we do.
All righty, thanks. Just jump in. We also look for strategic partnerships to augment community benefits, and I'll share one way that we're doing that. And where our expectation is our impact will be broad and will inform national guidance, strategy, and response to COVID-19. So we have an engaged governance where we look to make sure that our projects are involved in every aspect of this work. We have a steering committee that includes community members and principal investigators from projects that are part of the consortium. We have a data stewardship committee that's intentionally reflective of the kinds of projects and data and communities that would be, so that we're being responsive. And some of those happen to be actually project PIs as well. We have a publication dissemination committee that includes PIs and community members, and an external advisory board that's intentionally external, but also has both health system, healthcare, and research leaders, as well as community members that are leaders in their own right. So we were charged in the coordinating center to develop a community of practice. And that is the way we've thought about our work and how do we pull this consortium together, make sure that we're engaging not just the investigators, but also the community members in this work, because we do believe that their expertise is critical for us to be able to solve these complex problems. So if you look at, there is a whole literature on a community of practice that we had to learn about. It has three distinct ideas: community, obviously, who cares about this work, a select group of individuals with a particular interest in a topic, a domain, which includes a shared area of interest, and which is what we care about, and then practice, a shared body of knowledge, experiences, tools, and approaches. It's what we do together. And I'll share with you sort of how we've been thinking about how we support development of a community of practice as sort of an engaged approach to engaged research. One is we get together. We have project spotlights that are regularly done and featured. We have project-wide meetings. We have a regular newsletter. We provide support in terms of consent form review, as well as translation support. We also work together. We have an Evidence Equity Academy, which is a way for us to come together, understand the state of the science, and then think about ways to move that translation down the translational spectrum. So what do we know, and what's important for what we need to do going forward? And I'll share some highlights of our Evidence Academy from last year. We have, as you see here, we have our upcoming one in a couple weeks, in in less than 3 weeks. I'll also share with you CCPH, Community Campus Partnerships for Health office hours. It's a regular consulting service to support projects in engaged scholarship. We have realized that the projects come all along that spectrum of engagement, and how do we help people where they are and if they want to move to where they want to go. We also have an engagement resource center that pulls from projects and other places sort of the best evidence on how to do engagement, how to engage in the setting of a pandemic, and how that can reinforce the work that they're doing. We have a series of work groups similar to the domains that you have developed. And these are our first 5, and they're building and growing as we speak. I'll mention a little bit about common data elements, and I'm glad Warren is here because he'll be able to back me up. The whole point of this work is research, and to extend that foundation of research for underserved populations. And so the CDEs are critical to that, and it's part of the reason that we're doing this work. We also have RADx, my RADx RADxUP Home, which is our website, and I can get you that website. I actually think it's on the next slide. It's a repository for all of sort of these important documents, resources, project profiles, etc. We also have testing plan review, and we support the projects in thinking about their procurement as well. Because you all do a lot with data, I just thought that I would mention the common data elements. These are all obviously all collected in the same format by all the projects. These were developed by NIH and was sort of the dream of the NIH to have this kind of repository of common data elements, and then catalyzed by the CDCC. You all, I know, are very familiar with this. It started out as a pretty messy and imperfect process, and I will completely credit Warren and his team for moving us through this in a way that was really allowed me to see the sort of development of the process and the kind of grace that was needed to move from over 700 CDEs down to the 60 that we're working with now. And obviously this is an incredible resource, given the demographics that I described of the projects and who they're working with. It's an unprecedented opportunity to really understand what's happening in communities, particularly in the setting of a pandemic. It also gives us an opportunity to link these data with external data sources, and that will obviously augment the impact, we hope, in the future of this incredible resource and jewel. These are the 12 executive CDEs required across all of the RADx initiatives, so all of those 4 boxes. And here are the tier 1s that are required for RADx-UP. So another element of our engagement strategy is our engagement impact teams. These are teams of 2 team members that bring a combined expertise around project management and community engagement to support every single project. Every single project has an EIT or an engagement impact team that they're working with. They're their main point of contact for the project teams, and they support them through coordination around testing, around community engagement, around data collection and sharing. They work specifically, they're sort of their front door into although we have many doors into RADx-UP, but they really are their main point of contact to help us understand the challenges that the projects are having, and to also to support them in generating solutions. They help with assessing the testing methods, the supplies that are needed, help them with timeline management, a whole host of things, and also monitoring the progress of the projects and supporting them in making that progress. We also use communications channels as part of our, as you all do as well. We have a website, we use Twitter, we have Slack channels with different questions for the projects to be involved with, as well as as I mentioned, my RADx-UP home. CCPH provides incredible support and training for us. This is just a subset of the kinds of trainings that they've been able to provide. They provide free office hours, not just for the projects, but also provide that training for us within the CDCC, because you can imagine this kind of the breadth of the expertise that's needed to do this work means that nobody is expert in all of the expertise. And so one of the things that we've done is to make sure that we have a common language around partnerships, that everyone has sort of the opportunity to get training around the fundamentals of community engagement and those principles, to really understand structural racism, social determinants as a structural driver of health. And then one of the things that we've done recently is to work with projects to think about how to disseminate research findings from the community perspective, not just from the academic perspective. Their office hours are held weekly specifically for the projects. This training has the training on the left side of this slide has been for us internally in the CDCC, so that we all have the skill set to be able to support the projects. I mentioned the Evidence Academy. Our second event is happening on November 17th and 18th. You'll see that the first one, which is on the bottom right-hand of the slide, was focused on translating the innovations in testing. And here are some of the takeaways from that first Evidence Academy. The second one is really thinking about this bridging the infrastructure that's needed for equitable testing and vaccination. So moving us a little bit and still grounded in testing, but also having us think about equity in vaccinations as well. The takeaways from the first Evidence Academy, which brings together, I think we had over 300 attendees from NIH, from the academic PIs, from the and community members that came together in this way to think about the current evidence and what we need to do to move forward along the translational spectrum. And some of the key takeaways that came out of this was making sure we're providing testing in places that makes the most sense for communities, not for us in healthcare systems. That equity is needed for funding for COVID-19 testing and decision-making for community-based organizations that are partnering with researchers, and trust is a fundamental element for any effort related to testing and testing technologies. We also, again, get together. We just had our first RADx-UP scientific meeting in October. I guess that was just 2 weeks ago. And we had 11 project teams presenting some of their preliminary findings and lessons learned. It was really a fabulous meeting, longer than probably we needed it to be, or we could have sustained, but it just was riveting right up until the end. And it showed how so many of the projects were able to provide this sort of fuller picture of their communities by collecting and analyzing data. Community partners were also part of those presentations, and intentionally so, and really added to the richness of the conversation. Again, one of the key themes that was raised was community engagement and how essential that was to their success and trust. We have ways that we're trying to expand our consortium, community collaboration mini grants, and rapid research pilot programs. These are small grant programs, and you can see towards the bottom of the list there. The first one really focuses on community-based organizations that are out in the field and trying to get as many tests out as possible. We cover expenditures up to 50K. And then the rapid research project pilot are really more hypothesis-driven kind of pilot programs, and that's up to 200K over a 12-month period. I'm going to move through this. So we, Mickey, it really started thinking, we have this incredible infrastructure. We'll have over 120 research projects in communities across the country and the US territories. Is this going to be it? How do we think about the future? And so we started asking questions. The three of us started asking these questions. What if we could build upon the existing work of RADx-UP to address health disparities beyond COVID-19? What if we could come together to explore how to nurture, strengthen, and evolve our national network, systems, and partners to be at the ready so that whenever the next community disaster happens, which it always does, how can we be ready for that next public health threat? What if we could strengthen and enhance our ability to deliver community-engaged research so that we can serve as a blueprint for future emergency response in communities that are most impacted? Because we know the communities that we're partnering with now through RADx-UP are always those communities that are impacted by any community disaster. And what if we could leverage what we're learning now to address problems communities faced even before the pandemic started? And so we've been in this sort of space of thinking about how do we move from testing to this broader aperture of pandemic preparedness to this, and broaden still to this larger focus on health equity. And this is our sort of our 10-year vision that we're working towards with this sort of foundational question. What can we do as RADx-UP over the next 10 years to build upon current opportunities, enhance community partnerships that we've created to address disparities, both COVID-19 pandemic and beyond, with underserved populations, vulnerable populations? We used this process with our collaborators, Katie Brandert and Kim Howe, who led us through this process with over 120 community partners across the projects, academics, research staff, and that participated in 7 visioning sessions and 7 strategy sessions to get to this 10-year vision. One is a radical reimagining of our community research paradigm. The second is authentic, equal, trusting, and community academic partnerships, making sure we have the funding and infrastructure to sustainability to enable this long-term extended impact, strong data and research infrastructure that will enable improved rapid responses to these emergent challenges, and research findings that drive meaningful. So this whole idea of translation, how do we drive meaningful system impact and action? And then ultimately, how can we have equitable, holistic care for all that are part of our systems? So I'll end here and say that really we see RADx-UP as an unprecedented NIH investment in community engaged research that can address health disparities and advance health equity. It can be a blueprint to conduct community engaged research and really a blueprint for a response to a health crisis. And so with that, I'm going to thank the communities that working with us, the participants that are part of their projects. Those projects are project officers and NIH leadership, and I'm going to end here. Thank you.
That was wonderful, Giselle. Thank you so much. Let's see. I don't see anything in the Q&A.
There is
I do want to go ahead.
Okay, no, just David Eichmann in chat, I think, made raised a sort of very general positive question. We at the N3C have had discussions on generalizing the N3C thing to more general and new contexts. It would be very interesting to blend your perspective into this to ensure future work is equitable.
Yeah, I did scroll through. I did see the SDOH work group, work stream,
Domain team.
Domain team. You know, those of us a part of these consortiums come up with these umbrellas.
Yeah.
I did see the SDOH domain and did wonder sort of how much a focus on underserved populations might be there. And I saw the slide that in terms of, I'm not part of the enclave, so I can't see what's actually behind the glass door to know how the disparities that currently exist within the pandemic are reflected in the data quality that are in N3C, because we all know that we suffered very early on with sort of lack of data on race, ethnicity, and I imagine that it's probably remains an issue, certainly in data that's coming from health systems.
Well, it's been a big focus, and there's a chat, which I absolutely agree with, that Therese Madlock-Brown would be somebody to talk to, but this is really the disparities issue has been a major focus of both SDOH and really of tremendous interest in the N3C consortium. Obviously, we are dependent on the identities of the organizations that send us data, but we've got roughly 3 million COVID positive patients from all over the country. So I think we have, reasonable, although certainly by no means complete coverage. And Liz Zampino says we meet every Wednesday at noon PT. We'd love to. But no, it's really a fantastic group. I zoom into them every now and then, and really that absolutely is a really major focus. And also Peter Robinson in his machine learning efforts has put a big focus on fair ML algorithms and making sure that work to make sure that these things are equitable and deal with all communities to the extent we can. So certainly huge potential synergies. Harold says maybe promote Liz to panelist. Great idea. Can somebody promote Liz to panelist?
And Harold has a question actually in the Q&A while Liz is getting promoted. If only promotion was that easy in real life, right? Harold has a question about analytic methodology. There's lots of discussion about models, metrics, and analytic methods to take equity issues into account. Is RADx-UP thinking about a library of such methods beyond CDEs? It's something I think about all the time, but Warren and I haven't talked about. So right now we're working on just getting data into the hub, but maybe Warren, if you wanted to come off, it's something I think about often. I was excited to hear, I think I heard you all say something about concept mapping. Would love to know more about what you're doing with that. It's a methodology that I've used in a bunch of different places. We've had a couple fits and starts to think about system science methods and the way that we might be able to use that within the consortium. It's only been a year, and we've stood up a coordinating center from ground zero. And there's so much potential here for the work that we can do. So I'm gonna let Warren go ahead and comment on that.
Well, I think one, you're right, Giselle. We're still building the infrastructure, frankly, for all the different projects. But it's certainly not too early to think about how do we bring in some other kinds of models for analyzing the data that we're generating. Something you may not know about N3C is we're not just academic medical centers, but we also have the CTRs, the idea state CTRs that submit data to N3C. And so we do get actually a different view of some of those populations than we do just in the academic medical centers. So there is some opportunity to think about that with particularly from an SDOH standpoint across the many different data providers that we have. Yeah.
So I see Liz is I think promoted to panelist. So you
Thank
can,
you.
Liz.
yeah.
And there are a couple comments from Andrew, Ken, and Mary as well. Liz?
I had lost track of what the question was. What was the question you guys had for me?
I think they were asking you to be promoted to a panelist so you can share around the social determinants of health work.
Yeah, so I don't know if I necessarily have anything to share, but I'm more than happy to talk what we've been working on recently.
Right.
That'd be
So
very exciting.
a lot of things that we're working on currently is involved with the electronic medical record. So we're doing I was really curious to see the common data elements that you have decided to focus on. So that would be great to share that information with us so we can see if there's any correlation or any harmonization we can work on. So we're doing a lot of that. We have a lot of common data model mapping that we're doing. We're focusing a lot on the surveys that are given in institutions around social determinants of health. So that's something that we work on frequently. I don't know if you have any specific questions, but we meet every Wednesday. I know that's just another meeting, or I'm more than happy to set an intro email up with you and Charisse
Thank you.
Madlock.
Very generous. That's very generous of you. So when you say the SDOH questionnaire, so are we talking about food insecurity, housing insecurity, intimate partner violence?
Right.
Okay, so that's
Right.
And I think it's explicitly the ones that now, for instance, Epic has an SDOH module that some
Right.
institutions are starting to roll out. And then, so there's a set of questions that get given to different clinics. And right now they're not uniformly taken up, at least certainly not at Duke. So we're trying to figure all that out too.
Yeah, so we're focusing, I don't know if you're familiar with any of them, but we're focusing on Prepare, which is a very common one because Ocean supports it in Oregon. There's just a bunch of different measurement tools that we are working on that collect this information and then making it easily accessible in the electronic medical record. So physicians are able to access information when they're treating patients. Is very viable, as you know. Yeah. So we're more data oriented, but yeah, we'd love to have you.
Well, it's so important, and you know, we are limited by what we're collecting because certainly those 5 indicators of social stressors are important, and they are not really social determinants of health, right? I mean, we're talking about policies and practices, so they're sort of still a little bit more downstream than the upstream factors that actually lead to housing insecurity, that lead to food insecurity, et cetera. But it's still important, and I'm excited that we're even collecting any of this. When I was started this work 20 years ago, people were looking at me like, why do you even care about this? So it's exciting. I'm glad to know that that's there. There were a couple other comments. It looks like Mary, I completely agree. Disparities exist in every domain. It may not be explicit, but it's certainly coming to the surface. And then there were a couple other chats in there. That the environmental and rural domain teams are looking at health, at social determinants of health as well. And you all work together on collaborating on research addressing health equity questions. That's cool.
And I just add to that. So there's we use a OMOP common data model here. There's an Odyssey work group that's got excellent cross-pollination with the N3C domain team and social determinants in other areas. And one of the efforts there is to bring together lots of different folks who are doing things like the Gravity Project, and I think like what's happening in RADx-UP, to not reinvent vocabulary needs where they're there. So there's several different ontologies being developed that are capturing different domains, and there's an effort to bring those together and to make them visible to folks working in N3C, and I think making them visible to using both the CDEs that are developed in RADx-UP and sharing those back is probably one of the things we should take forward from here.
Yeah. Thanks for that, Andrew.
There are a couple of questions in the Q&A.
There are more? Did I miss them? I thought I.
No, you answered those.
Oh, okay.
Okay, well, this
All
is
right.
fantastic. Any other
Yeah.
thoughts, questions?
Thank you so much, Giselle.
Oh, it's my pleasure. Certainly my
Great talk, and very exciting, and an honor to have you with us.
Thank you so much for the invitation. It was great being with you.
Thanks. Take care. Bye-bye.
Thank you. Bye-bye.